Good evening to all of you. Dr. Divya, can you unmute yourself? We'll be starting the session now.
Yes, sir.
This is a series of demo classes which we are launching, and this is a prelude to our upcoming course on sexual health and sexual medicine, which will be starting on 15th of January. So, let me just introduce you to the subject before Dr. Divya takes over. Is my screen visible? Can you see clearly?
Yes, sir.
Okay, wonderful. Today we will be having this session by Dr. Divya. She's a professor in SMR Medical College, and she'll be talking on menstrual cycle, libido, and mood, what actually fluctuates and why. Very, very relevant topic to anybody who is practicing in the field of medicine, be it a general practitioner, be it a sexologist, urologist, or a gynecologist. Something very, very relevant topic. So we'll be starting this in another 5 minutes from now. I'd like to introduce you to our upcoming course. It's a course on sexual health. We've divided this into elaborate topic into two parts. One is the basic course. Name is Essential Concepts in Clinical Sexual Health and Medicine. In this, we will be taking up the basic sciences first: anatomy, physiology, biochemistry of sexual health and function, going to neuroendocrine pathways and sexual response cycle and sexual disorders, how to how do we define them, how do we diagnose them, the DSM-5 and other criteria. Then most importantly, we'll be talking about the pharmacology of sexuality, which drugs you have to prescribe, which drugs can cause sexual function, how to avoid them. Everything will be covered in great details by the best of experts in the country. And gender identity, orientation, and culture, it's a specialty of Dr. Divya, who is to start a session now. So she'll be taking this session. History taking, we'll give you an overview of male sexual dysfunction, female sexual dysfunction, and most important topic, masturbation and socio-cultural disorders. And in the end, we'll have a 2 to 3 hour session on clinical cases, where we will be taking up clinical cases which are commonly encountered and what is the best way to resolve the clinical problems. This is starting on 15th of January. Then this is followed by another course that's the Advanced Sexual Medicine Masterclass. This is a more detailed course. It will start with history taking and examination. Then it will be focusing on erectile dysfunction, premature ejaculation. We'll go on to address female sexual dysfunction, how to evaluate, how to manage, and psychosocial therapies for sexual dysfunction. Because anybody who is practicing sexual medicine realizes that it's all in the brain, and most of the patients require counseling and good psychotherapy, along with some drugs which are relevant, which will be told to you. We'll also take up genitopelvic pain and penetration disorders, very very relevant. Dyspareunia, very relevant topic. Then impact of any substance abuse drugs, alcohol, and psychotropic medications. Something which is very very relevant in times in today's times: digital media, pornography, excessive consumption, what can be the harmful effects, and the social behavior. Then sexual dysfunction due to physical illnesses such as maybe a cancer or a hypertension, diabetes. Everything will be taken up in a detailed fashion. So these are all 2 hour sessions and followed by discussions. So if you're joining, keep yourself free for at least 2 hours in the evening, and we'll be having almost 1 to 2 classes per week. Genital hygiene and sexually transmitted infections. Every second day we see patients of sexually transmitted infections, and they have concerns, in their mind that can this go wrong? Can I pick up a STD? And they are involved in some kind of practices. So very, very relevant topic. And this all will be followed again by some clinical vignettes and question answer sessions. All the sessions are followed by question answer sessions, and high quality vignettes will be discussed. We will be giving you a certificate. We'll be conducting a small MCQ feedback kind of questionnaire. We'll be sending out to you, and you can send it back to us at your leisure. And all the courses, all the classes will be available to you for next 60 days after the course finishes. So you have the access to these lectures for at least two months from the day the course finishes. So you can see them over and over again. You can revise. You can If you miss on something, you can go back, and you also become a certified sex therapist, and we will be giving out a certificate also. So today's class is very relevant. Another extremely relevant class comes next to next week. That is on 29th of December. It's an year end. All of you will be having some plans, but please take out 1 hour for this class. It's sex and pregnancy, taken by Dr. Mitali Srivastav. She is from Pondicherry University, and she has got a rich experience in female sexual dysfunction. She's practicing for almost 7 to 8 years now, and she is ESSM certified. That is, she is a European, sexual medicine certified expert, and probably amongst the very few in the country. So she will be taking this session, and she will be taking all sessions on pain disorders and dyspareunia also. So with this, we get back to today's session. And before we start, I would like to introduce Dr. Divya formally. Dr. Divya, she's a MD in physiology from Manakula Vinaykar Medical College and Hospital. She's a MBBS from Madurai Medical College. She also has done MBA and MSc in applied psychology, and she has been trained in various course. She has taken various courses in reproductive and sexual health, which includes the WHO course and also training for HIV prevention. And she has also done some workshops on LGBT, that is lesbian, gay, bisexual, transgender, queers, and intersex, and asexual people. And that's her specialty. She does a lot of workshops educating these people on HIV and other relevant disorders. She has also done a certificate course in gender identity, expression, and behavioral health. And she has got 28 peer-reviewed original research publications in various national and international journals. And her research areas include neurophysiology, reproductive physiology, psychology, medical educations, and transgender physiology and LGBT health. So, welcome, Dr. Divya. Welcome to this session, and we are extremely proud and honored to have you with us. So, over to you, Dr. Divya. You can share your screen now. We have a fair number of people participating. Please unmute yourself, and you can start your session, Dr. Divya.
Okay. Able to see my screen?
Yeah. Make it full screen. Yeah, it's fine now. Perfectly fine.
Okay.
Yes, ma'am, clearly visible, ma'am.
So, good evening, one and all. The topic for today's demo class is menstrual cycle, libido, and mood. What actually fluctuates and why? So, we all have learned about menstrual cycle, libido, all that. Okay. So, let me begin with the question: what primarily drives female libido? Can you can answer in chat, or you can, unmute yourself and answer. Option A, B, C, D, E. So we will all be tempted to say that the hormones drives libido. It's not so. One second. Why am I not able to?
Blame.
One second. One second.
Any concerns, Dr. Divya?
Yeah. When I'm opening this PowerPoint, no, it is like I'm not able to see the chart and everything.
You make it full screen, maybe that helps.
Yeah. One second. If I put it as in a slideshow, I'm not able to view this.
You want me to share? Then you can send it to me, and I'll download and
Yeah,
share.
that will be better, I think.
Okay.
Can
Please send it
I
to
can
me
I
on
WhatsApp you?
WhatsApp. Yeah, please send
I'll
it to
WhatsApp
me on
you.
WhatsApp. Yeah.
Just
Sorry for the delay, and it will take just 1 minute more, not more than
yeah.
that.
Yes, I have shared it with you, sir.
Okay, let me just download it in a second. Yeah.
Yes.
Yeah, I'm sharing it now.
Yeah.
So can you see the screen clearly now, Dr. Divya?
Yes, sir. Yes, sir. Yeah.
So moving to the first slide now, and I think we have done this question.
Yes. So the answer is uh, it is D. That is, female libido is controlled by brain, hormones, and the context. Next slide, please. So where does sexual desire actually originate? Answers. Yes. So sexual desire, we think it originates from our sex organs like ovaries, whereas it starts in the brain. That is mainly our hypothalamus, our limbic system, prefrontal cortex, as well as the very important reward circuits, which are dopaminergic pathways. Also, the sexual desire depends upon the emotional context and safety. So, genital response is not sexual desire. It is not just physical, it is actually neurological. Yes, sir. Next slide. Next question is, do hormones directly control female libido? Yes. So, but when you check two women with same levels of hormones, may or can have opposite or different sexual desire. So, common assumption we all have is hormones is equal to sexual desire, which is not. The reality is hormones modulate the sexual brain sensitivity, and libido is a brain based experience. So, hormones influence neurotransmitters and not the sexual behavior directly. Next slide, sir. So, can the participants please answer this? High estrogen automatically means high libido. True or false?
You can put this in chat box, your answers.
Yeah, false. Yes. And next slide, please. Yes. So here, even if the estrogen levels are high, the sensitivity to the estrogen matters more than the absolute hormone levels. Next slide. Yes. So now we'll see a small, this is one flowchart kind of thing that I have made. Uh, how is sexual function regulated? Can you name a few of the factors that regulate the sexual function with the clues given here? Yes. Okay. Next slide. Yes. So first one is central nervous system. So sexual function first is regulated by the central nervous system, that is hypothalamus, limbic system, and prefrontal cortex. Next one is next please. It is regulated by the peripheral genital system, that is vaginal epithelium, clitoral tissue, pelvic vasculature, and smooth muscle. Next. Also, the psychophysiological modulation also regulates the sexual function like mood, pain sensitivity, fatigue, body image, and inflammation. Next. Hormone influences the sexual function, but according to all this, it comes as a last: estrogen, progesterone, and androgens. So what do we say from this slide is sexual function it is not just regulated by the hormones, but it is a combined responsibility of central nervous system, peripheral genital system, psychophysiological modulation, that is mainly the mood as well as the body image and also the inflammation, along with the hormonal influences. Next. Yes. So here we should know about the hypothalamic pituitary ovarian axis. So all of you might be familiar with this. So this gonadotropin releasing hormone, pulsatility, determines the ovarian hormone output. So what happens? Estrogen and progesterone. Estrogen and progesterone feedback not only to the pituitary but also it gives feedbacks towards the amygdala, hippocampus, and prefrontal cortex. Hence, so what does this imply? Menstrual cycle is not just a uterine cycle or an endometrial cycle, it is a brain cycle. Stress, nutrition, sleep may alter GnRH, which will alter mood and libido. So, where we are heading is what are the regulatory factors of menstrual cycle and the sexual function during the menstrual cycle? Yes, next. Yes. So he can see here various neurochemical mediators of sexual function. Here we can see the neurochemical, that is estrogen, progesterone, testosterone, and prostaglandins. These are the very four important neurochemical mediators which regulate the sexual function during the menstrual cycle. Okay, so first one is estrogen. What does estrogen do? It increases the dopamine levels. It also increases the nitric oxide. Also, it increases the oxytocin sensitivity. Because with this three mechanisms, estrogen regulates the sexual function. Next one is progesterone. Progesterone, what does it do? It will cause increase in GABA inhibition, decrease in dopamine. Okay, so in the first or second slide, you would have remembered dopaminergic reward pathway, right? That is one important factor in regulating sexual function. If you see here, what does progesterone do? Progesterone decreases dopamine, whereas what does estrogen do? Estrogen increases dopamine. Can you tell me then what in what way this increase in dopamine or decrease in dopamine will affect the sexual function? Any of you? Any guess?
Ma'am,
Yes.
ma'am, dopamine is a both the features. Right? Dopamine is the excitatory and maximum cases in the in between response. Only for love cases and good aroma response, then in be excitatory work मतलब. But
Yes.
maximally मतलब is the in between work.
Inhibitory one. Okay. So
Yes.
in what do we say in generally dopamine increases the reward pathway. So it activates the reward pathway. In that sense, it slightly increases the libido and the sexual desire during the menstrual cycle. So that is what, as you said, it is right. It has more of the negative effect, but in this context, it slightly increases the libido as well as it increases the sexual desire. So in that case, the estrogen, which increases the dopamine, may increase the sexual desire as well as libido. So when is this estrogen levels increased during menstrual cycle? Which phase? Yes.
During follicular phase, ma'am.
Yes, very, very good, very good. So that is the point here. That is a catch here. Whereas during the luteal phase, this progesterone comes into action and it decreases the dopamine, as well as it also increases the inhibition. So you would have got a rough idea during the menstrual cycle what are all the neurochemical mediators and how this sexual desire and libido is mediated, as well as testosterone. If you see, testosterone is will increase the sexual motivation and increase sexual fantasies. So, can we now say that testosterone levels are very high in males? So, the sexual motivation and sexual fantasies are very high in males. Maybe that is just a fun part. But testosterone generally increases the sexual motivation, and it also has a similar, pattern of increase, just like estrogen. It is actually increasing during the follicular phase. Whereas here, the prostaglandin will increase the pain as well as it also reduces the sexual discomfort. So on the right side, if we see that progesterone and prostaglandins both may reduce the libido as well as sexual desire, whereas estrogen and testosterone may increase them both. So this is just a neurochemical mediator. I'll just show you the menstrual cycle and its variations. Yes. Next slide, please. Yes. So I made one chart here. You can see the parameters. So this is just a rough chart for you to understand. Here, there is a dominant hormone, okay? Then central desire, genital arousal, and somatic negative effects, okay? Whereas on the top, I have put the menstrual cycle days, okay? Menstrual cycle, day 1 to 5, then early or mid follicular phase, late follicular phase, that is day 13 to 14, then mid luteal phase 15 to 23, and late luteal phase. Okay, so this is just a rough flow chart for an idea. If you see here, the dominant hormone during the menstrual phase, there is none, whereas at early or mid follicular phase, the estrogen is rising, whereas it achieves its peak during ovulation, and mid luteal it is progesterone, and finally late luteal none. Whereas the central desire, if you correlate with this, the central desire during the menstrual phase, that is 1 to 5, will be low. Okay. Whereas during the early or mid follicular phase, it is rising steadily. Whereas the central desire, what is central desire? It is the desire that is controlled by the central nervous system, that is sexual. So this will attains peak during the late follicular phase or during ovulation because of the high dopamine. Whereas in the mid luteal phase, again, it starts decreasing due to high GABA tone, and in the late luteal phase, again, it becomes low. This is genital arousal. Next one, which is physical. It is low during the menstrual phase, that is first 1 to 5 days, that is pure lubrication. Whereas during the early mid follicular phase, it is improving. Whereas in the late follicular phase, it becomes optimal. And during the mid luteal phase, it starts declining. And in the late luteal phase, it is poor. Whereas the negative effects, like somatic effects like cramps, fatigue, are very high during the first few days of the menstrual cycle, that is 1 to 5. It is low during the mid follicular phase, and it is low during the late follicular phase, and again moderate during the mid luteal phase. And late luteal phase, it is very high, which we call it as premenstrual symptoms or irritability, pain, sensitivity. Okay, so this tabular column, I have made it as a flow chart. I made it as a graph. Next slide, please. Yes, you can see here the dotted red lines here. This is cramps or fatigue, the physical negative symptoms, pain, PMS, mood, all those things. The pink line here, which denotes the central desire and motivation for sexual function. Next, the blue line denotes the estrogen levels, and you can see the green line, which is the genital arousal and lubrication is. Then you can see the progesterone levels, which is in the yellow, which is given the yellow line. So generally we know about the hormones and its levels and everything, but the other important thing is, you can see here the dopamine, which will activate the reward pathway, is highest or at its peak during the ovulation. So as the menstrual cycle begin, we can have that first 1 to 5 during the bleeding periods. You have all these PMS symptoms and everything, cramps, fatigue. You can see this small peak here, and then you have the rise in the hormones like estrogen. You can see the estrogen rise up. Then you can see the central desire and motivation along with it, which rises up. And when it is peak, when the estrogen level is at peak, you can see the dopamine, which is reward pathway, which is activated. Also, you can see that genital arousal slowly rises, and also it when the nitric oxide levels are more, it leads to genital arousal, and it also reaches the peak during the ovulation, and slowly it falls down as the levels of estrogen comes down. So this is a graph which shows the uh, different phases of the menstrual cycle along with the parameters whichever we have discussed here on the left. Next. Yes. So we saw a few questions or myths in the beginning. Similarly, we'll have some more questions. So I had some theory part in the middle, and now we'll have some more questions. Why does libido often reduce in the luteal phase? I think you can give the answer. It is because of progesterone dominance. Okay, so this lower desire is not dysfunction, that is very important. This is physiological, it is not pathological. The lower desire or libido in the luteal phase or second half of the menstrual cycle is not a dysfunction, it is actually physiological. It is mainly due to the progesterone dominance, and we already told you, reduced dopaminergic tone. Also, it is also called as GABAergic calming. This leads to sedation as well as emotional dampening during that phase. Next. So, is PMS caused by excess hormones? True or false? It is false, because it is caused by heightened sensitivity to the normal hormonal changes, mainly the serotonergic dysregulation, they say. That is why even when you in many of the PMS patients, if they measure the hormone levels, usually that comes as normal, but the hormone sensitivity may vary in different patients, and this also has to be validated along with the patient's experience. Next, please. Okay, or mood swings during menstruation, all in the mind. Can you answer, please? Okay, we'll see the next slide. No, okay. Yes, so hormone withdrawal affects the neurotransmitters. Next, please. Serotonin fluctuation is there, which leads to vulnerability. Next. Brain sensitivity varies across individuals. Different individuals have different sensitivity towards the hormones. Yes, next. So biology plus psychology interaction leads to these kind of symptoms. Next. The brain is responding to real biochemical changes. Okay, so it is not just all in the mind, but the hormone along with the hormonal fluctuations, along with the neurotransmitters, along with the brain sensitivity affects the or leads to the mood swings. Yes, next. Reduced libido without distress should be labeled as, yes, answers please. You can also unmute and answer. Option A is sexual dysfunction, option B is hormonal disorder, option C is normal variation, and option D is psychiatric issue. Okay.
Dr. Divya, is it a normal variation?
Yes, sir. So, the reduced libido without distress should be labeled as normal variation because it is actually physiological. So, reduced libido is not pathological, it is not abnormal. But reduced libido with distress may be classified as abnormal or sexual dysfunction. Yes, because
And
during
itself,
the different phases of the menstrual cycle, the libido varies. It reduces, it increases. So if it doesn't cause any distress, it can be called as a normal variation. Next, please.
Dr. Divya, many patients, or maybe some of them will come with, persistent reduced libido, like for years or months.
Yes, sir.
So that can't be termed normal. But then
No,
how do we explain that?
yes, sir. Persistent reduced libido will lead to distress. So that is why, reduced libido in a cyclical pattern once in a month or sometimes, that can be called physiological. But if it causes distress to the patient, then it is surely abnormal. That is a dysfunction.
So the keyword here is distress.
Distress. Yes, sir.
And if it's prolonged, it is not causing any distress, it's fine.
When it is prolonged, usually it may cause distress.
Okay.
But if it is continuous and it stays for a longer time, yes, it is distress or it is abnormal. So that is what the next question is. When does that normal variation become a disorder?
Well, my question is, how can best interpret the judgment accuracy, judgmentally, mood swimming and mood alteration is high risk in the menstruation phase and during luteal phase? Because the estrogen reason is behind of this. Estrogen is a every day, every section is a fluctuately, matlab. So mood irritations and irritability receptor is exceptionally high during the phase. How can
Okay.
you prevent this risk in women?
I didn't
And
get
that determine the mood psychologically, mood judgmental.
psychological mode. Can you please repeat the question, sir?
He's being
Yes, sir. I think you're breaking. Can you please repeat the question, sir?
Rajkumar, your voice is breaking. Can you
Yeah.
repeat, or you can write in the chat box? We will take the question.
Yes, sir.
Yeah.
okay. Okay, ma'am.
Yes, sir.
Ma'am,
So,
generally,
yes, sir. Again, I think uh, okay, I think I'll go on with the slide. So it was a very
yes.
good question. From normal variation becoming a disorder, you can see here distress is the key. Functional impairment also matters. Along with that, context also matters more than the cycle phase. So when during a cycle, when there is a decrease in libido, the context also matters. So if the patient feels they are having a impairment, also they also when they also have an impairment, or even if they feel that they have an impairment, it is definitely abnormal, as well as it can be called a sexual dysfunction. So practical rule is distress, functional impairment, and context, all these things matter. Next slide please, sir. Yes. So, how do medical conditions alter the desire across the cycle? So, what are the common medical conditions that we come across which alter the desire mainly the thyroid disorders, which can lead to mood and libido changes, and PCOD, androgen imbalance and body image, depression, in which there is neurotransmitter imbalance, as well as intake of SSRIs for depression and other mood disorders may lead to libido suppression. So, always before treating a patient with reduced desire, we need to review the medications and the comorbidities the patient is having. Yes, sir. Next. So, what should we remember? This is the last slide. What should we remember when discussing female sexual health? Here, not just hormones, but brain plays a very, very important role, and individual hormonal sensitivity matters. Normal variations are common. Compassion is the clinical skill. So, with this quote, understanding replaces judgment and knowledge reduces stigma, I would like to end my presentation. Yes, sir. Thank you. Next slide, sir. So, these are the various references. Yes, sir. So, if I can get that question from Rajkumar, sir, I think we can answer it. And other questions also are there.
Yes, ma'am. My
Yes, sir.
simplified question is, my
Yes.
question is how can sustainable in women during menstruation phase mood alterations?
Yes, sir.
Because the high risk in women as a menstruation during menstruation phase, because reason behind of this every second estrogen is a मतलब सर्च पीक इज a मतलब वेरिएबल पीक मतलब एवरी सेकंड मतलब जिससे कि कहने का मतलब ये है कि जैसे मेंस्ट्रुएशन फेज के अंदर क्या होता है कि हर सेकंड हर मिली सेकंड्स के अंदर द एस्ट्रोजन पीक ऊपर नीचे होता रहता है इज अ मैन हाई रिस्क इन मेंस्ट्रुएशन फेज एंड एट लीस्ट एज कंपेयर टू एट लीस्ट रिस्क इन luteal phase. So how can sustainable mood alteration in menstruation phase in women? Because generally is mood alteration high risk in women as compared to men. Because so my question is, so how can best interpret the sustainable mood alterations?
Mood alteration, maybe we can monitor, sir. We can use the various charts that analyzes the mood. We can have a diary where we can note down about the various changes, and also we can, if you really wanted to, alter the mood changes and irritability, we can also have some interventions which can be prescribed by the psychologists who are associated with. And regarding the mood changes, it is not just the menstrual cycle or the sexual hormones alone. As
Yeah,
I
yeah,
discussed in the slide, other hormones also can have effect. Other
yes,
conditions also can have it. We can find out if the subject is having, or patient is having, any other psychiatric conditions like depression or anxiety.
yeah, yeah,
These things can influence their mood during the menstrual cycle. So complete analysis of their hormonal profile, their psychological profile, only can give us a proper reason or cause for their mood alterations, and then you can give manage the patient very easily, sir.
okay.
Yes, sir.
Thank you.
Thank you, sir.
If there is any other question, you can ask. You can switch off your mic and ask. Let me see the chat box. Okay. Not many questions in the chat box, Dr. Divya, and practically you've answered. And it was a very clear and lucid presentation, and a very nice way of presenting, asking questions, and then explaining them. So it was very impressive actually, and it just underlines your knowledge of human sexuality. So the stress she is stressed on, sexuality is a biopsychosocial behavior, especially if you take in case of women, it's all the more biopsychosocial. So you have to have the right hormones, right body, right mood, right place, and
Yes,
then the female, kind of, uh, what should I say, is sexuality is optimized.
yes,
Otherwise, anything goes wrong, things don't take proper shape.
yes, sir.
So, Dr. Mitali, you're there. Would you like to comment? Dr. Mitali is one of our very renowned faculty members, and she has got rich experience.
Hi, Mitali, are you there?
Uh, well, she's logged in, but I think she's not responding. Maybe some network issues.
Yes.
Yeah. Anyway, would you like to give some concluding, would you like to summarize your presentation, Dr. Divya?
Yes. So, Generally, menstrual cycle, we consider it as a uterine cycle, ovarian cycle, or a hormonal cycle. It is not so. It is also the brain cycle. So, the various hormones, they play a very major role, and the way the hormones influence brain function, the neurotransmitter levels, the neuro, endocrinological pathway, the hypothalamo pituitary axis, all these things interplays a female's sexual function during the menstrual cycle. So the loss of libido to a very small extent, or if it is doesn't causing a distress, and if it is only during that particular phase, that is your luteal phase, when the progesterone levels are more and the dopamine levels are less, that may not be referred to as a dysfunction. But if it is a distress and if there is a functional impairment, it can be called as a dysfunction. So the sexual desire, as well as the central desire, as well as the libido, it depends upon the neuro endocrinological, the entire process. So when we assess a subject with a central desire or libido dysfunction, we need to assess all these parameters, not just the hormone levels. We need to assess the neurotransmitter levels. We need to assess their other endocrine organs, endocrine secretions, and order what are all the comorbidities the patient is having. Only when you estimate all these things, and when you have a complete profile, you can treat the patient in an effective way. Yes, so that is all about my topic today.
So,
So,
excellent
excellent
presentation.
presentation.
Is my voice?
Is my voice? Yes, sir. Yes, sir. I can hear you.
Okay.
Okay.
So
So
now
now,
we like to brief you about our upcoming course, Essential Concepts in Sexual Health and Medicine, which I've described initially, and it begins on 15th of January next year. So we encourage you to register for the course. You will soon find a link in your inbox, and you can simply go review the course and register for the course if you feel like. And thank you, Dr. Divya. It was actually a wonderful presentation, and we are really, we're going back much more informed. Thank you so
yes.
much. Thank
Thank
you
you.
so
Thank
much.
you so much for the opportunity, sir.
If there are no more questions, we will end the presentation. Okay, we're ending the presentation. Thank you.
Thank you.
Bye.
Thank you.
Bye. Bye. Have a good night.
Thank you, ma'am.